Good morning, Dr. Phil here. Today we will be discussing on intravenous anesthetic agents. Features of the ideal intravenous anesthetic agent. Rapid onset. Rapid penetration through the blood-brain barrier by the drug is achieved by being unionized at blood pH and highly lipid soluble. Rapid recovery. Early recovery period produced by rapid redistribution of the drug from the brain to well-perfused tissues, particularly muscle, down a concentration gradient as the plasma concentration of the drug decreases. Later recovery period. Speed of recovery is related to the rate of metabolism of the drug. Slow drug metabolism results in prolonged hangover effect. Risk of accumulation when repeated doses or infusion are used. Provides analgesia even at sub-anesthetic concentrations. Minimal cardiorespiratory depression. Does not cause post-op nausea vomiting. No excitatory phenomena on induction. No emergence phenomena. Does not interact with neuromuscular blocking agents. No pain on injection. No venous sequelae. Safe if injected inadvertently to an artery. Non-toxic. Does not cause histamine release. No hypersensitivity reactions. Water-soluble, long shelf life, and safe for patients with porphyria. Mechanism of action. Thiopental enhances inhibitory synaptic transmission by activation of the chloride channel on the beta-1 subunit of the GABA-A receptor. Propofol also enhances inhibitory synaptic transmission by activation of the GABA-A receptor. Propofol also inhibits acetylcholine release in the prefrontal cortex and some parts of the limbic system. Propofol inhibits NMDA glutamate receptors and inhibits fatty acid amide hydrolase, which degrades endocannabinoids, especially anandamide. This results in increased amount of endocannabinoids in the brain. Ketamine is an antagonist at the NMDA receptor at the calcium channel pore. Serotoninergic, muscarinic, nicotinic, and monoaminergic receptors, partial mu receptors as well. Ketamine inhibits sodium channels in the neuronal tissue. High doses has local anesthetic actions. Ketamine is a partial agonist at the kappa and delta receptors and results in analgesic effect. Opioid effects are not antagonized by naloxone. Ketamine reduces presynaptic glutamate release. Etomidate enhances inhibitory synaptic transmission by activation of the chloride channel on the beta-1 subunit of the GABA-A receptor. Indications. Thiopental. Induction of anesthesia, maintenance of anesthesia, anticonvulsant, and ICP reduction. Propofol. Induction and maintenance of anesthesia, sedation, and anti-emesis. Ketamine. Induction of anesthesia, especially in field anesthesia, bronchodilation, sedation and analgesia, neuraxial anesthesia, co-analgesia, and antidepressant. Etomidate. Induction of general anesthesia, especially to achieve cardiostability during induction. Contraindications or caution. Thiopental. Airway obstruction, hypersensitivity or allergy, risk of hypotension such as patients with cardiovascular disease, severe hepatic or renal disease, reduced metabolic rate such as patients with hypothyroidism, adrenocortical insufficiency, and extremes of age. Myasthenia gravis or dystrophia myotonica. Respiratory depression is exaggerated if thiopental is used. Thiopental is the default anesthetic agent used for induction in obstetrics. Give the correct dose, avoid underdosing which risks awareness in GA, and overdosing which risks cardiorespiratory depression of the fetus. Thiopental is contraindicated in porphyria. Thiopental can precipitate bronchospasm in asthmatic patients. No other drug should be mixed with thiopental due to risk of crystallization and thrombosis. Propofol. Airway obstruction, hypersensitivity, and adverse effects. Ketamine. Absolute contraindications, airway obstruction and raised ICP. Relative contraindications: cardiovascular disease, frequent procedures requiring repeated administration, visceral stimulation, and outpatient anesthesia. Etomidate. Contraindications includes airway obstruction, adrenal insufficiency, long-term infusion for sedation, contraindicated in porphyria. Watch out for adverse effects. Adverse effects: thiopental, hypotension, respiratory depression, tissue necrosis if extravasation, intraarterial injection can result in gangrene, laryngospasm, bronchospasm, allergy, thrombophlebitis. Adverse effects of propofol: cardiovascular depression, respiratory depression, excitatory phenomena, risk of awareness, pain on propofol injection, allergic reaction, propofol infusion syndrome. Adverse effects of ketamine: emergence delirium, nightmares, hallucinations, hypertension, tachycardia, prolonged recovery, salivation, increased ICP, allergic reaction, risk of neurodevelopmental toxicity in young children for neuraxial anesthesia. Adverse effect of etomidate: adrenal cortical suppression, excitatory phenomena, pain on injection, nausea vomiting, venous thrombosis. Doses: thiopental. IV induction dose for adults is 3 to 5 mg per kg. Use lean body weight for obese patient. For males 100 kg, females 70 kg. Children 6 mg per kg, elderly 3 mg per kg. IV infusion for status epilepticus 2 to 3 mg per kg per hour. Per rectal dose is 50 mg per kg. Propofol. Induction of anesthesia: IV 1 to 2 mg per kg in adults, children twice this dose, elderly half this dose, obese patient use lean body weight. Tiva: 4 to 12 mg per kg per hour or 4 to 8 micrograms per mil effective site concentration. Antiemetic dose: 0.5 to 1 mg per kg per hour. Ketamine. Induction dose is 1 to 2 mg per kg IV or 5 to 10 mg per kg IM. Use lean body weight for obese patients. For sedation and analgesia, up to 0.5 mg per kg. Infusion dose is 50 micrograms per kg per minute. For sacral extradural block in children, the dose is 0.5 mg per kg. This increases the duration of LA for up to 4 times. Nasal and oral dose for ketamine is 6 to 10 mg per kg. Rectal dose is 10 mg per kg. For pain syndromes, for example, patients with CRPS have been treated by infusions of 0.1 to 0.2 mg per kg per hour over 5 days. Etomidate IV dose is 0.2 to 0.3 mg per kg. Use lean body weight in obese patient. Per rectal dose for etomidate is 6 mg per kg. Physical properties: the structure of thiopental, propofol, ketamine, and etomidate is as shown. Chemical name of thiopental is sodium 5-ethyl 5, 1-methylbutyl 2-thiobarbiturate. Thiopental is a sulfur analog of the barbiturate pentobarbital. For propofol, it is 2,6-diisopropylphenol. For ketamine, it is 2-O-chlorophenol 2-methylamino cyclohexanone hydrochloride. Ketamine is a cyclohexanone derivative of phencyclidine. Etomidate is D-ethyl 1-alpha-methylbenzyl imidazole 5-carboxylate. Etomidate is a carboxylated imidazole. Formulation of thiopental: thiopental is a yellowish powder. Nitrogen in the ampule prevents reaction with atmospheric carbon dioxide. 6% anhydrous sodium carbonate is added to increase its solubility in water. It is available in single-dose ampules of 500 mg to be dissolved in distilled water to produce 2.5%. Freshly prepared solution is stable for 24 to 36 hours after mixing. The manufacturer recommends discarding it after 7 hours. Formulation of propofol: propofol comes in 0.5%, 1% or 2% emulsion in soybean oil, egg lecithin, glycerol providing 1.1 kcl per ml, with or without EDTA, which is bacteriostatic, and sodium hydroxide. Propofol should be discarded and administration lines changed after 12 hours of opening the vial at room temperature, as propofol is a potential culture medium. Ketamine is formulated as a solution containing benzethonium chloride, which is a preservative, hydrochloric acid, water for injection, and sodium chloride. Concentrations available: 10 mg per ml, 50 mg per ml, and 100 mg per ml. Ketamine is a racemic mixture of S-dextro and R-levo enantiomers. Undiluted ketamine vials should be stored within 15 to 30 degrees Celsius, protected from light, and discarded 28 days after initial use. Diluted ketamine, such as 50 mg per ml to 10 mg per ml with sterile water, is chemically stable for up to 182 days at room temperature, even under exposure to light. Etomidate can be formulated in a clear aqueous solution containing propylene glycol 35%, or lipid formulation containing medium-chain triglycerides and soybean oil, etomidate lipuro. Etomidate lipuro ampoules contain 20 mg of etomidate in 10 ml, resulting in 2 mg per ml. Etomidate is a pure R-dextro enantiomer. Etomidate lipuro should not be stored above 25 degrees Celsius. Etomidate lipuro contains no antimicrobial preservatives and should be opened and syringed up aseptically, injected immediately, and the unused portion discarded. pH: for thiopental, 10.8, propofol, 7 to 8.5, ketamine, 3.5 to 5.5, and for etomidate, 6 to 8.5 for etomidate lipuro. pKa: for thiopental, it is 7.6, propofol, 11, ketamine, 7.5, etomidate, 4.2 for etomidate lipuro. The ideal agent should have long storage times without enabling microbial growth and should be preservative-free. Derivatives: thiopental has no derivatives. For propofol, it is phos-propofol and agent PFO713. Derivative of ketamine is pure S-dextroketamine. For etomidate, it is methoxycarbonyl etomidate and carboetomidate. Other features: propofol is water insoluble. Thiopental, ketamine, and etomidate are water soluble. Thiopental is not stable in solution. Propofol, ketamine, and etomidate are stable in solution. Thiopental does not have a long shelf life. Propofol, ketamine, and etomidate have a long shelf life. The ideal agent should be water soluble, stable in solution, and have a long shelf life. Pharmacokinetics: protein bound: thiopental 85%, propofol 98%, ketamine 12%, and etomidate 75%. Volume of distribution: liters per kg. Thiopental 2.5, propofol 2 to 10, ketamine 2.5 to 3.5, etomidate 2 to 4.5. Distribution half-life alpha in minutes: thiopental 1 to 2, propofol 2 to 3, ketamine 2.7, etomidate 2 to 4. The ideal agent should have a short distribution half-life. Elimination half-life beta in hours: thiopental 6 to 15 or 11.5, propofol 5 to 12, ketamine 2 to 3, etomidate 2 to 5. The ideal agent should have a short elimination half-life. Context-sensitive half-life for propofol: 2-hour infusion is 16 minutes, 8-hour infusion is 41 minutes. The ideal agent should have a short context-sensitive half-life. Lipid solubility: thiopental, propofol, ketamine, and etomidate are highly lipid soluble. The ideal agent should be highly lipid soluble. Percentage unionized at body pH: thiopental 61%, propofol almost 100%. The ideal agent should be 100% unionized at body pH. These four drugs are metabolized by the liver. Thiopental follows a zero-order process. The ideal agent should have a fast metabolism. Active metabolites: thiopental and ketamine have active metabolites, which are pentobarbital and norketamine and dehydroepiandrosterone nor ketamine respectively. Propofol and etomidate do not have active metabolites. The ideal agent should not have active metabolites. There is accumulation with repeated use of thiopental, but not with propofol, ketamine, or etomidate. The ideal agent should not have accumulation. There is hangover effect with thiopental use, but not with propofol, ketamine, or etomidate. The ideal agent should not have a hangover effect. These four drugs are eliminated renally. Clearance of thiopental mils per kg per minute is 3.4, propofol is 30, ketamine is 16 to 18, etomidate is 10 to 20. The ideal agent should have a high clearance. Bioavailability. For thiopental, propofol, and etomidate, it is 100% if given IV. For ketamine, 100% if IV, 93% if IM, 20 to 25% if oral, 50% if nasal. Pharmacodynamics. Cardiovascular system. Thiopental and propofol results in a drop in blood pressure. Etomidate does not cause a change in blood pressure. Ketamine causes increase in blood pressure. The ideal agent should be cardiostable. Thiopental and propofol results in decrease in cardiac output. Ketamine results in increased cardiac output. Etomidate does not cause a change in cardiac output. Thiopental and propofol commonly cause an increase in heart rate. Ketamine as well. Etomidate does not cause an increase in heart rate. There is decreased systemic vascular resistance with thiopental and propofol use. Ketamine and etomidate does not alter systemic vascular resistance. The ideal agent should not alter systemic vascular resistance. Arrhythmias may occur with thiopental, propofol, ketamine, or etomidate use. The ideal agent should not be arrhythmogenic. Thiopental and ketamine is painful on arterial injection. Propofol and etomidate are not. The ideal agent should not be painful on arterial injection. Only propofol has no sequelae from arterial injection. Thiopental, ketamine, and etomidate has sequelae from arterial injection. The ideal agent should not have sequelae from arterial injection. There is low incidence of venous thrombosis with thiopental, propofol, and ketamine use, but not for etomidate. The ideal agent should not cause venous thrombosis. Respiratory system. There is respiratory depression with thiopental, propofol, and etomidate use, but not with ketamine. The ideal agent should not cause respiratory depression. Thiopental causes increase in bronchial muscle tone. Propofol and etomidate does not cause a change in bronchial muscle tone. Ketamine decreases bronchial muscle tone and is a bronchodilator. The ideal agent should be a bronchodilator. Laryngospasm. Thiopental may cause laryngospasm. Laryngospasm is rare with ketamine or etomidate use. Propofol depresses laryngeal reflexes and does not cause laryngospasm. Nervous system. There is rapid onset of hypnosis with thiopental, propofol, ketamine, and etomidate. Thiopental 30 seconds, propofol 20 to 40 seconds, ketamine 1 to 2 minutes, etomidate 30 seconds. The ideal agent should have a rapid onset of hypnosis. Duration of hypnosis in minutes for an IV bolus. Thiopental 5 to 10 minutes, propofol 5 to 10 minutes, ketamine 10 to 15 minutes, etomidate 2 to 8 minutes. The ideal agent should have a short duration of hypnosis. Recovery due to redistribution occurs with thiopental, propofol, ketamine, and etomidate. Recovery due to metabolism occurs with thiopental. The ideal agent should have a fast recovery due to redistribution, with or without metabolism. Excitatory effects on induction does not occur with thiopental, but occurs with propofol, ketamine, and especially etomidate. The ideal agent should not have excitatory effects on induction. Only ketamine has analgesic effects, but not thiopental, propofol, or etomidate. The ideal agent should have analgesic effects. Thiopental has analgesic effects. Propofol, ketamine, and etomidate do not. The ideal agent should not be analgesic. Emergence delirium may occur with ketamine, but not with thiopental, propofol, or etomidate. The ideal agent should not have emergence delirium. Intracranial pressure decreases with thiopental and propofol use, increases with ketamine use. Etomidate decreases ICP. The ideal agent should not alter ICP. Cerebral blood flow decreases with thiopental and propofol use. Cerebral blood flow increases with ketamine use. Etomidate decreases CBF but CPP is not altered. The ideal agent should not alter CBF. Cerebral metabolism decreases with propofol, thiopental, and etomidate use, but increases with ketamine use. The ideal agent should decrease cerebral metabolism. Thiopental, propofol, etomidate, and ketamine do have anticonvulsant effects. The ideal agent should be anticonvulsant. Pain on IV injection occurs with propofol and etomidate but not with ketamine or thiopental. Propofol and ketamine is non-irritant on subcutaneous injection. Thiopental is irritant on subcutaneous injection. The ideal agent should not be irritant on subcutaneous injection. Gastrointestinal and renal system. Hepatic enzyme induction occurs with thiopental use but not with propofol, ketamine, or etomidate use. The ideal agent should not induce hepatic enzymes. Hypersalivation is rare with thiopental or propofol use. Ketamine causes hypersalivation and increased secretions. Etomidate does not cause hypersalivation. The ideal agent should not cause hypersalivation. Hepatorenal blood flow is decreased transiently with thiopental or propofol use. Ketamine and etomidate does not affect hepatorenal blood flow. The ideal agent should not have any effect on hepatorenal blood flow. Hepatotoxicity and nephrotoxicity does not occur with thiopental use. Propofol is rarely hepatotoxic and may cause acute liver injury and propofol infusion syndrome. Ketamine is hepato and nephrotoxic with chronic use. Etomidate is not hepato or nephrotoxic. The ideal agent should not be hepato or nephrotoxic. Post-op nausea vomiting occurs with ketamine and etomidate use but not with thiopental and propofol use. The ideal agent should not cause post-op nausea vomiting. Musculoskeletal system. There is minimal decrease in skeletal muscle tone with thiopental use. Propofol decreases skeletal muscle tone. There is increase in skeletal muscle tone with ketamine use. Etomidate decreases skeletal muscle tone. The ideal agent should provide muscle relaxation. Thiopental, propofol, ketamine, and etomidate do not trigger malignant hyperparaxia. Etomidate may decrease uterine muscle tone. Thiopental, propofol, and ketamine do not. The ideal agent should not affect uterine muscle tone. Propofol and ketamine are safe to use in porphyria, but not thiopental and etomidate. The ideal agent should be safe to use in porphyria. There is decrease in intraocular pressure with thiopental and propofol use. Ketamine increases intraocular pressure. Etomidate does not alter IOP. The ideal agent should decrease IOP. Compared with other induction agents, ketamine has anesthetic, amnesic, and analgesic actions. It is sympathomimetic, resulting in increased catecholamines, cardiac output, and systemic vascular resistance. Ketamine is a respiratory stimulant. There is preservation of laryngeal reflexes and tone of the upper airway. Ketamine causes bronchodilation by antagonizing the effects of acetylcholine and serotonin at the bronchial tree. R-levoketamine has better antimuscarinic effects than S-dextroketamine. Ketamine has multiple routes of administration apart from intravenous, such as rectal, intramuscular, oral, nasal, extradural, and intrathecal. Ketamine can be used in patients with porphyria. Ketamine is associated with severe bladder damage when used abusively. These are my references. Thank you.